This is Julie Miller with Virginia Cardiovascular Specialists. Thank you so much for joining us. I'm here with Dr. Jiho Han at our Stony Point office, and he is going to be talking about amyloids today, which is a fairly new topic for us. So we will be recording this meeting, so we will be able to send it out to folks after the meeting later this week. Also, we ask that folks use the messaging to type any questions.
I can't hear it.
And we'll address those at the end. If you can please make sure to mute your device, we'll try to do that for you as well.
Hi, good afternoon. Can you all hear us?
Yes, yep.
Yes, thank you for joining us. Julie Miller is one of the most important people in our group who helps coordinate, events and information. So we thought it would be important to discuss, it's a topic called cardiac amyloid. And for old doctors like me, it's been around for a while, but recently we have new drugs that can help. So in medicine, when we think about a new topic or a new problem, we always talk about cases. And we'd like to share one case that may illustrate some of the topics, and then we'll look at cardiac amyloid as how to understand it, and then how to diagnose it, and then finally how to treat it. And a little bit of technology driven, but it's an interesting problem. So this is a very nice person who is now in his 90s. He was seen by many different physicians. He was really active, tennis player, had some coronary disease, and also has a pacemaker, and eventually needed a heart valve, and then diagnosed by a wonderful cardiologist downtown, Dr. Ellenbogen, with cardiac amyloid. And the question is, how did this occur? He had carpal tunnel surgery for his family history, allergy to penicillin and non-typical medication. And his EKG was normal back in 2009, but then over time, 10 years later, you can see the electrical voltages going down. And so his echocardiogram shows really a thick muscle, and his heart function was normal, as you can see it working vigorously. And he had what we call biatrial enlargement on echo. So in knowing this gentleman over the last 11 years, how did we miss this diagnosis? He had carpal tunnel, he had back pain, he had a very thick ventricle on echo, but low voltage. He didn't like beta blockers. And the main thing was treatment was not available until last year. So we assumed that his problems stemmed from valvular disease, and because he was a great tennis player, that he was okay, and that his shortness of breath over time was due to just aging and maybe coronary disease. So we didn't really think about this amyloid. So keep in mind that he has a lot of the signs that we'll be looking at. And one of my partners says always, you do not see what you don't know. So that's what this journey is about this afternoon, is try to take a look at things that we can look at it. So what is cardiac amyloid? How do you diagnose it? How do you treat it? What are the symptoms? What are tests needed? Do you have to biopsy things? And is timely diagnosis important? So amyloid, it comes from the Latin word starch. It's a specific staining pattern called green birefringence. It's what we call beta-sheeted fibrils. And there are a lot of proteins that make up this family of amyloid. Everything in our body, including immunoglobulins that we use to treat disease, as well as albumin, things that make our bones, keratin, are really precursors or are amyloid proteins. And it comes from two different families. You're going to be learning that cardiac amyloid are two major classes. The protein comes from the bone marrow. Our bone marrow makes blood and also immunoglobulins. They're made by plasma cells. And the other form comes from our liver, which we call transthyretin. And of the transthyretin variety, it can be hereditary in a rare population, and most of it are mutations, which we call wild type or senile. So the rarer form are AL amyloid. This is sort of a dangerous situation. It's a relative of multiple myeloma. Plasma cells make overabundant immunoglobulins, and the light chains are parts of these immunoglobulins that fight disease. Unfortunately, these little light chains, which are protein, are toxic to certain cardiac fibrils and cause weakness of the heart muscle. And so these people have normal-sized hearts, but their heart function is degraded, and they present with a large tongue, and they can have periorbital purpura. And this is what this looks like. Periorbital purpura is that bruising around the eyeballs, and they have one of the largest tongues known. So this is an infiltrative toxic problem, and it causes illness, death rapidly unless you diagnose it, but it can be treated. It's rare, and it's usually in people over the age of 40, and 20% die in 2 months. And one of the most greatest amyloid people at Mayo Clinic says that it's a race against time. To diagnose this problem, you need blood analysis. And in the old days, we used to do what we call serum protein electrophoresis. And our blood, that gooey stuff, is partially albumin, and then the other are our immunoglobulins. Now, we don't do the serum protein electrophoresis readily, but we have what they call immunofluoroelectrophoresis. And we collect urine to do this. So the blood tests that your doctor might order are called immunofluoroelectrophoresis of your serum and urine, and they'll also collect urine samples, which is painful to do over 24 hours. And they'll do another serum test to look for these little light chains. The other form of amyloid comes from the liver. But this form that comes from the bone marrow is really super critical to diagnose fast because of the toxicity. So again, your doctor will have to exclude this first by ordering 2 different blood types, and then will ask you to collect urine to specifically look for these excessive proteins. So you have a little bit of an idea that cardiac amyloid from the bone marrow, although it's rare, can be a tough thing to diagnose, but it's super easy because it's just 2 blood tests and a urine test. The other kind, that's from the liver, we call ATTR amyloid or transthyretin. It's the hereditary and wild type. So transthyretin is the protein that the liver makes, but it's produced in excess. It's really a carrier molecule for thyroxine, which is the energy metabolism, and it's the misfolding of this carrier molecule that goes awry. Can you imagine if all the 18-wheelers that used to transport everything, after they did their job, they just like stuck around, parked, and your highways would be crowded with all these unusable 18-wheelers. And that's what this amyloid does. It's an overcrowding, overfilling, useless protein that causes the disease. We now detect it more in the 80 to 90-year-old population, but as our technology gets better, the whole idea is to detect it earlier. People have a better prognosis, males more frequently than females. And a lot of the patients have thick walls, and about 16% of patients who undergo aortic valve surgery with TAVR or transaortic valve surgery actually have this form of amyloid. A lot of people have pacemakers, and we think that maybe 20 to 30% of the population in their 80s could have this disease. So we're seeing amyloid every day. And it's staged in 1, 2, and 3 by biomarkers, really easy to do. And it's the deposition of these carrier molecules. Again, think about all the trucks on the highway after they did their load just hanging out, causing a traffic hazard. Carpal tunnel syndrome is really frequent, usually both hands. The protein gets deposited in the spinal spaces and it causes spinal stenosis. It causes rupture of the biceps tendon. And a lot of people get orthopedic surgery of their shoulders, knees, and other parts of their joints. Significant population have pacemakers because it infiltrates the conduction system, and many have atrial fibrillation. And the problem is when they have atrial fibrillation, they get clot. And this is what a clot in the left atrial appendage might look like. It's that gooey stuff, and that triangular space is actually the left atrial appendage. So this form of amyloid that the liver produces can cause heart failure even with normal ejection fraction. And what's really a hallmark is this deposition in joints, in tissues, back pain, carpal tunnel, joint pain, and the echo showing a really thick ventricle. And there are different ways to diagnose it with echocardiography, which is suggestive but not diagnostic. And it causes low voltage because this stuff is like a bad crab cake. You don't have a lot of crab material, but it's the protein, the muscle is not working very well. So EKG signal goes down. And this is what we saw, 2009, normal voltage on the EKG, which is the height of the EKGs. And then 10 years later, you see the voltage getting smaller. There are a lot of different ways cardiac MRI can be helpful. And the key thing, though, unfortunately, a negative MRI study doesn't exclude the disease. So most of us start with what they call a pyrophosphate scan. And this is really a bone scan. It's a pretty simple test done at the hospital. And the heart should not take up this technetium pyrophosphate. They grade it on a scale of 1 to 3. The problem is that as we get older and we have amyloid, it will be positive. But in the earlier form of the disease, it may not actually pick it up because you're waiting for the deposition to occur. So it's only right about 60 to 70% of the time in excluding the disease. And this is sort of, when they say, wow, get a PYP scan, it's really cool. But this is what the scan actually looks like. It's really not that fancy. And then they have to do what they call SPECT to make sure you're not picking up bloodstream. So it's nothing incredibly sophisticated. It's a very simple test, but it can take 1 to 3 hours in the hospital. So if your PYP scan is negative and all of your AL labs are negative and you still suspect it, biopsy would be the next step, but it can be dangerous to do these things. So you have to work in concert with your cardiologist. And right now, current biopsies are done down at VCU or in other academic centers. The biopsy is considered a gold standard if you have more than 4 samples, and it can differentiate the different kinds of amyloid. So we have sort of a quick run through of the liver form. It's important to know that if you're not a mutation, there are certain populations that have the hereditary form. And these are in Irish people and also from West Africa. And a certain population have this mutation in Northern Ireland. It is an autosomal dominant trait, which means that if you have the gene, you're going to pass it to your kids. But variable penetrance means that you may not express that gene. And the genetic testing is really easy. And a lot of people have neuropathy. And you can do genetic testing through Invita. Super easy, spit in a test tube, mail it in, and you'll have an answer within a couple of weeks. The problem with this disease is atrial fibrillation can cause stroke. And a lot of people with amyloid with AFib get into big trouble. And so we're at the point where if you diagnose this thing, what can you do to treat it? So right now, the drug tafamidis or Vyndamax is being used to stabilize these proteins. Some of the earlier drugs can block the proteins from forming, and then they're working on other immunoglobulins. So blocking the formation of the the bad protein, we can also help to remove fibrils. And one of the earlier data comes from the tafamidis trial, where they used the drug, and over a long time course, it really took over a year to see that there was symptoms, and then it did prolong survival. Unfortunately, the drug is super expensive, but there are ways to get a hold of it. And Angela, our medical assistant, can help you to do that. And she's been working very, very hard. If you have the bone marrow form, you have to go to a hematologist and can get a bone marrow transplant or get treated with Cyborg D protocol. So it's a lot of stuff that we just went through. The main thing is you have to be suspicious. Step 1, exclude the amyloid from your bone marrow. Very easy to do. Your doctor will order some serum blood work and a urine test. If you don't have this, then you can move on to the liver form. If there's any question, you should get a bone marrow biopsy. The second way to get the liver form is to get the PYP scan and also get the genetic test. And that's probably the easiest. If your scan is positive over 1.5, then you will get treatment. If it's negative or under 1.5 or intermediate, then we may do another scan in 6 months to a year, may get an MRI, or actually can get a cardiac biopsy. And everyone should get genetic testing. This is a fancy algorithm to look at how to do this, and it can be available. This is from the Journal of American College of Cardiology. So amyloid is challenging because we're seeing people every day with this disease, but we haven't been able to recognize it until recently because we didn't have great treatment. We have to follow the story of our patients and how you're feeling. And it's a multidisciplinary way to diagnose the problem. You have to talk to the electrical doctors, the oncologists, as well as your primary care physician. My partners here, Dr. Kundor is an expert, and Dr. K.R. Shah downtown at VCU, they actually have a wonderful amyloid clinic as well. And your doctors might order an echo, a pyrophosphate scan, an MRI, and in some cases might need to get an MRI or a biopsy. So it's a problem that's underdiagnosed, and I don't want us all to think we have amyloid. It just requires high index of suspicion. But if you can diagnose it early and also be on the vigilance as time goes on, the treatment can ensure a better quality of life and a longer life. And especially for atrial fibrillation that can cause stroke, early diagnosis is really critical. And there are a lot of resources, especially on the Mayo Clinic YouTube channel, on our VCS website, and through your physicians. So I thank you for your time going through this quick run through, and we'd like to open it up for any discussions or questions.
Dr. Han,
Yes, sir.
it's Mike Copley. I hope you're having a good day, and thanks for doing this.
Mr. Copley, good to see you.
A quick question. In my particular case, I guess we found this early, and I'm going through the Vendamax process now. Should I push these folks to hurry up because it sounds like time is of the essence, or am I good to go to wait?
Right. So again, if you have the AL variety, which you do not, it is important to, I think earlier the better, but it's more on the weeks to month. But I think the earlier stabilization is better. It's just imagine if you had a bunch of your grandkids over and they're messing up the house, better get it in order before it gets too rough. But it is, what's really important, again, for everyone is that if you are suspecting, if your doctors are suspecting the amyloid, so critical to get the blood work and the urine test for the AL variety, the plasma cell variant. But if you don't have that, then you do have some time. But it's not good to wait for years. It's probably something that should start within a few months at least.
Okay, good. We're down the road pretty good, so I think we're okay. Thank you for that.
Yeah, sure. Good question. Yeah, these screens and challenging. I have something in the middle of my screen says Dorothy Hamilton is requesting remote control of your screen. I'm not exactly sure what to say. Yeah. What do people think?
This is Sarah Ulmer. I'm wondering if I need to be concerned about this.
It's going to be important, Ms. Ulmer, to go through the protocol, but again, they would have to look through everything and specifically, but you know, this is a good opportunity for you all to educate your primary doctors and your cardiologists too, that if you mention it to them, they can do the simple screening as well.
So you do it through your primary care?
Mostly through cardiology, but if they're aware, again, it's the constellation of, you know, the EKG with the echo and then all the orthopedic carpal tunnel. If you have a pacemaker or have had valve surgery or a lot of joint procedures, then these are the things to look for.
Okay, because Dr. Gilligan is telling me that I'm having PVCs too close together. Again, he's doubled my medication and he's talking maybe another ablation.
Are you in love? Sometimes falling in love can make your heart fall like that.
I've been married 40 years.
And you are in love. Yeah.
I don't think that's it.
There's one question whether what's critical is this amyloid protein, it's not just one protein, but there's so many different kinds. And it has been implicated in Alzheimer's and other disease states. And it's the folding, they're learning more and more about it as time goes on. So what we talked about today is the cardiac form of amyloid, specifically the transthyretin program, the protein, and then the other was the immunoglobulin protein. But it's not just one protein. One of the other good question is that in people who are refractory to AFib treatment with ablation, sometimes this can be the answer, is that the reason why they're refractory is because they may have underlying amyloidosis. So it does need to be investigated in people who've had multiple ablation procedures.
Okay. Yeah, this will be my third one.
Yeah.
Okay. I missed the very beginning of this, but it sounds like it could be genetic and they can tell by your urine and I guess your blood work.
Right, that's a very good question. So there are three different varieties. The first, the AL from the bone marrow, is done by 2 blood tests and a urine test. From the liver form, it can be hereditary or it can be a mutation. And we call this the wild type. In the old days, they called it senile because it was found more in older people. So we would always start with the blood test to exclude the dangerous kind first. And then the second, for the liver, we do the genetic testing, which actually screens for all the genetic tests related to the heart, especially through Invita. And then we would do the imaging, the PYP scan as a start. So
tell me again, what was the second one?
Yes, most of us will have the liver form, which is the ATTR or transthyretin amyloid. And we always get genetic testing to exclude hereditary forms because that's really important for not you, but also for your family. And then we would get the imaging studies, the PYP scan done at the hospital.
Okay. Okay.
The doctor,
Angela, if you're on, can you comment on what's the response of Vindamax and their, help with their finances? Well, maybe Angela is no longer on the. Our medical assistant has been very helpful in working with the Pfizer Vindamax Corporation, or they have some type of a foundation that she's been helping, but it's a lot of work because it goes through a lot of financial screening stuff.
Dr. Han, this is Mike again. May I ask one other question, please?
Sure, of course.
When we go through the protocol to determine that you're not in the bone marrow category,
Mhm.
but you have a low grade score and you're just at 1.5 on the metric side, do you then stop or should you do a biopsy to make sure that everything is in line?
Right. That's a good question. If you know that you don't have the bone marrow kind, but you have intermediate scan for the PYP, which comes from the liver, what do you do? And we have gone, if the clinical suspicion is super high, then we do actually recommend biopsy. If not, then we would just repeat the scan in the next 6 months. A lot of us have gone to MRI. But the problem again is that MRI, if it's completely normal, it doesn't exclude it in the future. It's normal now, but it could be abnormal later on. So we just have to keep that in mind. The biopsy is the gold standard. However, in normal people, cardiac biopsies can be dangerous because you can have perforation and you have to have a really good reason to do so. Again, it is practice make perfect in the people who do a lot of biopsies, such as at heart transplant centers, that can be done safely. But it's an important decision that has to be thought well out in advance.
So otherwise, the medication is the way to go.
Yes. If your scan is 1.5 and you have it, then I would start on medicine. That's a pretty strong driver. I think most of us would start therapy. Yes, sir.
Okay. Thank you for that.
Well, again, it's a very complicated topic, but it's not complicated on a day-to-day basis. So really appreciate you guys joining us on a beautiful afternoon. I'd go out there and, have some fun and walk around. But again, any questions you can direct towards our website. And again, we're here to help. We really appreciate you joining us on this nice afternoon.
Dr. Han,
Yes, sir.
you are my cardiologist, so I'm going to bring this up to you in my next appointment. Would that be fine?
Of course, yes.
Thank you.
Yes, thank you.
Dr.
And what?
Are there various genes involved in this disease, or are there very few genes involved?
Right. The question is the genetic basis. So the hereditary amyloid, which is an autosomal dominant trait, they've actually isolated several different gene types. I think one of the slides showed the Val16 variant. There's a West Congo variant and another variant that comes from the Irish population. So those are pretty rare. We actually have not found, one of my partners has a patient who is the hereditary form. The hereditary form of amyloid has much more neuropathy. That's another hallmark. This stuff gets deposited. We didn't emphasize that as much in our tissues and the nerves, and it causes a lot of polyneuropathy, and that's what the genetic form of amyloid does.
The TTNI gene is not involved in this, is it, to your knowledge?
I'm not familiar with the TT, but the in vitro genetic testing actually tests for all the genes that can cause ATTR amyloid. There are multiple genes. Yes, ma'am.
Dr. Han, are there any symptoms that we need to look for?
Right. So that's a tough question because it's a slow process over time. So usually people will have carpal tunnel, like maybe 5-6 years ago, they would have a lot of multiple orthopedic surgeries. And then as the disease progresses in the heart, people get very short of breath. They develop heart failure with normal ejection fraction. They develop heart block and may require pacemakers. They get neuropathy. They develop atrial fibrillation. The hard thing is that a lot of these are signs as we get older, that's what can happen. But in a specific pattern with that background history, and then with a specific pattern on EKG and echo, that's what would lead us to suspect amyloid.